Hypermotor neuron pathologies tend to be things like CVA, spinal cord injury, MS if the motor neurons are affected, cerebral palsy if the motor neurons are affected. So those are your common upper motor neuron pathologies, and we will talk about the symptoms that you see, and then in the next section we'll kind of talk about some more symptoms. So you want to be able to describe the signs of motor tract or upper motor neuron lesions. We're going to talk about myoplasticity and spasticity, what they are, and how you tell what they are. So you get loss of function with upper motor neuron syndrome, similar to lower motor neuron, but different, of course. So paresis and paralysis with lower motor neurons, you get paresis and paralysis because there's a lesion in one of the lower motor neurons, and you get it just in the area served by that lower motor neuron, or one or more of the lower motor neurons. With upper motor neuron syndromes, you tend to get paresis and paralysis in patterns. So with a CVA, hemiplegia is a common pattern where you have weakness on one side of the body. With a spinal cord injury, paraplegia and tetraplegia. Paraplegia is body below the arms, and tetraplegia is all four limbs. Another word for tetraplegia is quadriplegia. And those, with paresis and upper motor neuron lesions, with hemiplegia, you get inadequate facilitation of the lower motor neurons because you have damaged upper motor neurons. Paralysis usually occurs with spinal cord injuries in muscles innervated by lower motor neurons below the level of a complete spinal cord lesion. So there's nothing wrong with the upper motor neurons or the lower motor neurons, but the tract in between is what's affected. And so the lower motor neurons are just not getting any signals. You get impaired selective motor control. So we said the lateral corticospinal tract provides selective motor control of the limbs. Well, interruption of those signals prevents that, and it profoundly affects the ability to use the hand. And loss of selective motor control interferes with fine movements. Decreased or absent muscle tone can happen in the early stages of upper motor neuron issues. We'll talk about that in a minute. So just as a review, muscle tone is the resistance to stretch and resting muscle. And muscle is categorized on a continuum. The resistance ranges from flaccid, which is a complete lack of resistance, and you tend to see flaccidity or hypertonicity in lower motor neuron lesions or in upper motor neuron issues where there's an interruption between upper motor and lower motor. So flaccid is a complete lack of resistance. Hypotonia is abnormally low tone. Normal tone, it's normal. Spasticity and rigidity are both hypertonia, so abnormally high resistance to passive stretch. Spasticity is velocity dependent, meaning that it increases with faster movement. Rigidity stays the same regardless of movement, so it's velocity independent. The causes of flaccidity and hypotonicity include lower motor neuron lesions, like we said before. Developmental disorders, particularly genetic disorders, tend to cause flaccidity or hypotonicity. When you're in the central nervous system shock stage of upper motor neuron lesions, like with a spinal cord injury or a cerebral injury, it's called spinal shock or cerebral shock, which causes temporary hypotonia. When an acute upper motor neuron lesion interrupts descending motor commands, the lower motor neurons are affected and become temporarily inactive, usually due to edema or inflammation of the affected area and loss of descending facilitation. Once they get out of that spinal shock or cerebral shock period, then it goes over to hypertonicity, goes over to spasticity. So a lot of times, especially with spinal cord injuries, they'll give people massive anti-inflammatory treatments to decrease the time that they're in central nervous system shock. When you see someone when you're working in acute care and you see someone the day after their stroke or the day of, they are usually flaccid or very hypertonic. And then later on, a week or more later, they're going to have spasticity or hypertonia. So hypertonia is either spasticity or rigidity, so velocity dependent or velocity independent. You have abnormal reflex, usually hyperreflexia after that spinal shock period, and abnormal co-contraction because we lose that selective motor control. Hypertonia is spasticity or rigidity, abnormally strong resistance to passive stretch. Spasticity is usually caused by chronic upper motor neuron lesions, CVA, MS, CP. Rigidity is caused by some upper motor neuron lesions, but also by basal ganglia disorders, and we'll talk about that in chapter 16. So rigidity is definitely more common with basal ganglia, and spasticity more common with chronic upper motor neuron lesions. So when we say it's velocity dependent, it means a faster movement produces more hypertonia. So you get changes in muscle tissue and you get neuromuscular overactivity that contribute to spasticity. It develops as an adaptation for paresis or paralysis, and sometimes it can kind of help with stability. Spasticity can kind of keep you, if you have paretic or paralyzed muscles, it can add a little stability in your movement. It usually spasticity begins to develop 1 week post-stroke or within a few weeks post-spinal cord injury. And the body's going to adapt to the spasticity with myoplasticity or neuromuscular overactivity. Myoplasticity is an adaptive change within a muscle in response to changes of neuromuscular activity level or to prolonged positioning. So contractures are part of myoplasticity, that increased number of weak actin myosin bonds, muscle disuse atrophy. Contractures can make dressing, hygiene, and positioning really difficult. Sometimes they can be beneficial if they're providing stability that you don't have because your muscles are weak, but that's not a best case scenario for sure. Following upper motor neuron lesions, disuse atrophy is usually less severe than denervation atrophy that you get with lower motor neuron lesions because your upper motor neurons are affected, but your lower motor neurons still provide a little bit of the normal neurochemical input to skeletal muscles. So the disuse atrophy is not with upper motor neuron lesions, you're still getting a little bit of that from lower motor neurons. Disuse decreases the motor cortex representation of the disused body parts, leading to further paresis. And when we say it decreases the motor cortex representation, it's sort of like somebody took an eraser and sort of smeared that motor homunculus. So you don't quite have that one-to-one mapping that you had normally. Myoplasticity can definitely contribute to spasticity, contractures and atrophy and weak actin myosin binding. Neuromuscular overactivity can cause hyperreflexia, which is the muscle spindle input um, leads to neuromuscular overactivity, and excess reticulospinal tract drive excessive reticulospinal signals to the lower motor neurons. So usually if you compare like upper and lower motor neuron issues, lower motor neuron tends to be hypotonic or flaccid and hyporeflexic. Upper motor neuron tends to be hypertonic and hyperreflexive. So that's kind of one way to differentiate between the two. With upper motor neuron lesions, you can also get abnormal muscle synergies because normally the muscle synergies are working to do movements together, but abnormal muscle synergies is activation of muscle groups all at once, and so you can't perform the desired results. So the example is, this is a picture from the book, and the person post CVA is trying to reach both arms up, and one arm reaches up, and the other one, instead of extending the elbow, it abducts the shoulder and flexes the elbow instead of extending. And so you don't get the desired effect. You try one motor act and it basically the wrong muscles are being activated in order to do it. So instead of being a normal muscle synergy where it's helping you do the motion, it's the abnormal ones where it's getting motion that you don't want. Spasticity affects approximately 20% of people post-stroke, 47 to 70% of people with MS, so that's a pretty high percentage, 34% of people with spinal cord injury, and greater than 90% of those with CP, and 50% of people with traumatic brain injury. So there's a measure of spasticity that's called the modified Ashworth scale. It's actually a measure of muscle tone, but they're inconsistent. Like a lot of the subjective scales, they're going to be inconsistent in inter-rater reliability and in reliability from one time to another. But you can compare the person to what they were previously, and you can see how it's changed, like they have more spasticity or less spasticity. But it is hard to get a consistent score on clinical measures.